situation, a very similar situation in another very beautiful Mediterranean country, which is Cyprus, which also has legal provisions in place for the diversion of people who are on drug charges to treatment, which is hardly ever used, as far as I know, but there may be people in the room who know more recently from Cyprus than I do. We have moved beyond the decriminalisation of Portugal and other countries. We're now looking beyond decriminalisation itself, because we have a talk from Canada, from Scott Bernstein, about the prospects for legal regulation of all drugs.
So it's Labor Day in Lebanon. I'm just going to go. Thank you, and thank you for coming. So I'm mostly not going to be talking about decriminalization, but if you're patient and hang on a little towards the end, I will talk a little bit about how what I'm talking about may relate to conversations about decrim. And so what I am going to be talking about is legal regulation. And so just at the offset, I'll define that a bit, and just define it as a government-established rules for a non-medical access to drugs. And that includes all points of the supply chain, so it's production, it's distribution, all the way to access and consumption. And let me back up a bit and just say that I'm with an organization, Canadian Drug Policy Coalition. We're a national network of about 70 organizations within Canada arguing for progressive and policy reform on drugs that are based in evidence and include human rights and social inclusion. So, where's the duty? There we go. Okay, so in Canada, we're experiencing a serious overdose crisis, and the numbers are staggering and unprecedented, and 11 people are dying every day there. And we've had a large scale-up of harm reduction that's happening in the country. It's not necessarily sufficient, but in some ways it looks as if it's having an effect of plateauing that number, but not reducing it and not getting us back to levels which are acceptable, which is basically 0 overdose deaths. And largely the cause of this problem is due to a contaminated illicit drug supply. And so we now have a toxic soup of sometimes a dozen different chemicals in illicit drugs, of which many of them are quite deadly, including analogs of fentanyls. And so people may be thinking they're buying heroin, they're getting something that may not include any heroin at all. And so it's very serious. And so there's a growing consensus in Canada that problems related to substance use are actually a public health issue. It should be dealt with public health tools rather than law enforcement tools. And I just want to say, like, so in my definition, it's not necessarily widely accepted, but in our definition of public health, it includes all sorts of things. It looks at it includes social inclusion, it includes human rights, and also includes looking at the harms of the policies created. So it's not necessarily medical per se. And so there are calls from people who use drugs, advocates, politicians for safe supply, and also regulation. So I want to apologize in advance for the amount of information on these slides that are going to hit your eyeballs in the next few minutes. So I'm available. Please come and talk to me or email me. I'm really happy to talk about this stuff. And of course, the other context in Canada is we legalized cannabis about 6 months ago, created a legal regulated market for non-medical access to cannabis. So that's an ongoing experiment. But the questions arise: what does regulation mean? And what would different stakeholders support? So a couple of years ago, a group of organizations in Canada, part of our coalition, created a collaboration called the Regulation Project. And so our aim is to advocate for legal regulation of currently illicit drugs in Canada for non-medical use. A Canadian Drug Policy Coalition and another organization based in Vancouver, Pivot Legal Society, are working on this particular piece I'm going to present, which is about a regulatory framework for Canada. So phase 1 of this project, it started fall last year, and it's going to continue for about 1 year, sort of this fall. We're going to develop this framework and make it easy to understand. It's not there yet, as you'll see, but getting there. We'll get some initial feedback from stakeholders about what this process looks like, what the models look like, and we'll revise the models a bit based on that and start ramping up for broader consultation across Canada. And then ultimately we'll write some papers and briefs about where we are at that point. Phase 2 is to develop models that are much more user-friendly and hold a series of focus groups across Canada and ultimately adapt these models for some kind of web-based input. And our goal is, right now, I'm just threw a number out of about 20,000 Canadians or so is an ambitious goal to gather input for over a course of a year or so. Phase 3, which isn't on here, and it's where my thinking's evolving, is that we need to make this platform adaptable and flexible enough that we can now share it with partner organizations around the world who might want to put this into their own context and put it out. So why make a regulatory framework? So there's a lot of research and commentary about how to regulate drugs and what to do, particularly in different places, including in Canada. They're generally good models, but they're not very digestible. So they're often too academic or too complex, or they may be prioritizing, say, a more medical phased approach rather than other things. And the other things that I think is often missing is the idea about consumer preference and uptake of the model. And so while we're constructing these and getting feedback, we want to make sure that people who consume the drugs are willing to consume them in these types of models we create. So our goals here are basically assess, improve the models based on lots of diverse stakeholder input, broaden the discussion in Canada to include the conversation of how do we regulate drugs, not just should we regulate or not, and then ultimately create a knowledge base that we can use for advocacy to government to say that these models have support from a broad swath of the public. Okay, so creating a discussion model, we have 4 classes of drugs we worked with: opioids, stimulants, sedatives, psychedelics, based on just researching and looking at harms and benefits of use and patterns. And we looked at regulatory levers, so basically that's just what governments can use to control how the market works. I'll talk about that in a minute. And for each substance we looked at under those categories of drugs, we gave 3 options along a spectrum: most liberal, middle ground, and then most restrictive. It's incomplete at this point. We haven't included all substances. We started simple just to test the model out. We'll add more as we go. And I think it's possible that we're going to ultimately be able to suggest regulating like similar things similarly without looking at specific ones. And we tried to focus on the factors that we felt reduced harm the most and also encouraged people to make safer choices. So a researcher in Canada, Mark Hayden, documented about 120 or so regulatory levers, just things like taxes or packaging or other choices we could make that would regulate the market. And so they fall basically into these 3 categories and then the subcategories under them around like client tools or distribution tools and manufacturing marketing tools. And so they might include things like where you can buy it for the client ones or how much you can buy. Distribution might be, where can they be consumed outside or inside a consumption site, for example. And then around manufacturing and marketing, like how is it packaged, how is it marketed, who owns what. And out of these, we've chosen 4 ways to handle them, basically just generally. Things like the age or the store hours, for example. We'll just talk about generally for all models. We'll do some of these regulatory levers we'll address for each group, for things like warnings or branding. And then some we'll talk about specifically for each substance. For example, like where is this substance sold? And then finally, some of them we just like, they will be dealt with somehow, but we don't need to address them. For example, like, you know, cash or credit, available, things like that. And so we just to simplify this, we chose to not do it all. Okay, so this is blank for us to have a big breath because the next slide has a lot of stuff. Don't read it, please. I will be happy to show you it up close, but it's our models and it's very dense. But here we go. So the other aspect of this is a long few rows in a spreadsheet that wouldn't fit on a PowerPoint slide. So we're going to see these in 3 pieces. Okay. Yeah, don't read that. But let's cut off a little bit. Here's what you need to know. Along the left here, so this is for opiums. This is the part that's cut off at the top. It says a spectrum of regulatory options for opioids. So right now we looked at 4 opioids that are down this column here: injectable hydromorphone, diacetylmorphine, heroin, poppy tea, methadone, and Suboxone. And then this is the first part of the spectrum. Here's most liberal, and then these green bar here have just a category of if it's free access and take home. As you move further to the right, it says you need licenses required, and you can take it home, but you don't need a medical referral of some sort. So then, what we did, for example, looking at injectable hydromorphone and heroin. We have a row for that, and the right here is where the bar for that substance starts. And so everything included in this purple bar is what we thought was an acceptable option under that public health model. So those are the available options we could choose from. So, okay, next part of the spreadsheet comes in. We're moving towards middle of the ground and more restrictive. We now have, over here you have free access, but there's consumption restrictions. Here you need a license and a medical referral, but you can still take it home. Down here we have, you need a license, but you have a restriction on consumption. And so as you can see, we also now have on the purple line here, option 1 is what we chose. And this is the most liberal option. It's a license is required with a medical referral, so you have to go through some training to get it, but you can take it home and you can access it through a dispensing machine. The next row goes towards the latter part of the graph. Very small, don't worry, I'll show you this later if you want to see it. So here we have medical prescription and take home, license with a medical referral and a consumption restriction. You have medical prescription and consumption restriction, the most restrictive we have. So that's basically a heroin-assisted treatment program. So for option 2, we have 2 choices. We recommended. We said one is a license access as a consumption site, okay, and a medical license access at a consumption site. And then finally, for the third option, we have the hat. So, for each model, we're going to present information to the stakeholders about the substance itself, about important aspects of the model where they're considering, and then pros and cons that we identified from the model. And so, for example, if we look at option 1 from what we just looked at, which is a dispensing machine with a license and a medical referral, important aspects are you have to do some training, you need a doctor's referral to the program but not a prescription, and you have to access it through a machine. Pros are you get 24/7 access, it reduces illicit consumption, connects you with some health information, requires users who are referred to get some training, and it also provides autonomy. Cons would be there could be possible diversion, there's no monitoring for complications like overdose, and we haven't included in this model access for those first users, which is a very important consideration to think about, but we haven't gotten there yet, and also access for those without access to medical care. So examples of questions we're going to ask stakeholders, like which do you like of these? Do you prefer one or the other? What challenges or barriers do you see? who are you? Are you a consumer? Are you a doctor? If you're a consumer, what do you take, how often? And then would you use this model, why or why not? And also, would you be willing to use a safer substance than you're using now if legal? And then, and also things like demographics. And finally, the question relating to this panel is, should drugs outside this legal system be criminalized? And so often I'm told that legal regulation is the far end of a spectrum where you have prohibition over on one side, decriminalization, and then legal regulation. That's not true. And we have that as example is the way that cannabis was legally regulated 6 months ago, is there are actually quite severe criminal penalties for consumption of cannabis outside the legal system. So you're allowed to possess and consume 30 grams of legal cannabis. If you have illegal cannabis, I'm not sure how they would tell, but if you have cannabis from somewhere else, you're still subject to criminal sanction. If you pass a joint to someone underage, you could be subject up to 14 years of prison. And so it's actually this very narrow pathway that did not include decriminalization for cannabis in Canada. So it's something we need to think about. We're obviously recommending a broader decriminalization goes along with a legal regulatory model, but it's important to also get feedback from stakeholders about their feelings on this and educate them about that. Thank you.